patient to taper off the steroids, and ACTH steam test came back normal. Actually, I was looking in the literature to see is it anything about improving the gland function after pituitary, and I found to taper off the steroids and ACTH steam test came back normal. Actually, I was looking in the literature to see is it anything about improving the gland function after pituitary, and I found to taper off the steroids and you are like a 30% function of the pituitary gland for 30%. I think careful dissection is very important, and it is not really the goal of the surgery, but with careful dissection you might be able to. I think case 4 is a very nice case that I did with Pablo in my fellowship. After this case, I will be almost done. This is like the case that I want really to show is courtesy of Pablo, and then I want to show in this case how we can remove the giant pituitary tumor with this new techniques, 30-degree endoscope, also using the extracapsular by manual dissection, and with all the instruments that we have. The video is a little bit long, but I think it's really good to watch because the step by step are very important. You see, this was a giant pituitary tumor going all the way to the hypothalamus, pushing the hypothalamus. The patient came with confusion to the hospital with all the instruments. You see here nicely the video is a little bit anatomy that we see at the beginning, and then the area that is challenging is the retrochiasmatic area that we will see in the tumor. So drilling the cella, checking with the navigation, the arteries. Now opening the dura. So we do like reverse V shape. So I learned from Pablo. So removing the intracellular part of the tumor, and then after removing the intracellular, this is a retrochiasmatic tumor, which is very, very challenging to remove because sometimes you don't see it and then you just leave the tumor there. You see you are done, but there's a lot of tumor. Obviously, we use navigation all the time. Try to now is 30-degree endoscope to do retroinflammatory dissection. And then you see how much tumor is there. If you are not experienced, you remove the intracellular part and you think you are done. But you see, you go all the way, it's all tumor. So removing a tumor from retroinflammatory space, and then this is the time that you feel the diaphragm is completely open. And then you see the hypothalamus here, you see. But you see, you go all the way, intermediate from all tumor. Now is the time you think the tumor we are done. So removing a tumor from retroinflammatory space, and then this is the time that this is the thing that I learned from Pablo to put titanium clips to reapproximate the diaphragm and then switch the high flow leaf to low flow. You see, you go all the way. Now is the time you think now we are done. So removing a tumor from retroinflammatory space, and then this is the time that this is the thing that I learned from Pablo to have titanium clips to reapproximate the diaphragm and then switch the high flow leaf to low flow. You see, you go all the way. Now is the time you think now we are done. Last case, I removed a tumor from retroinflammatory. This is a very challenging case. This was not in our institute. This is the operating that I learned from Pablo to have the titanium as a piece just to reapproximate the diaphragm. But I wanted to bring it up, switch the high flow to all of us. You see, you go all the way. Now is the time with headache and now last case, I removed the tumor from retroinflammatory. This is a very challenging case. This was not vision. This is the operating that I learned from Pablo. We decided titanium as a piece just to reapproximate the diaphragm. But I wanted to bring it up, switch the high flow to all of us. But you see, you go all the way. Now is the time with headache and last case, I removed the tumor from this is a very challenging case. This was not vision. This is the operating that I learned from Pablo. We decided titanium as a piece. I think the answer coming from the literature. If you see here, if you debug transnasally, you affect the supply of the branches of the inferior hypoglossal artery. Also, you compromise the venous drainage of the inferior pituitary artery. Very high chance of bleeding in the residual tumor superiorly. But if you do it transcranial, actually it's not like that because you preserve the function of the vessels that they are supplying the tumor superior. So from this, if you see, this happens in outside hospitals. In the residual tumor superiorly. But if you do it transcranial, actually it's not like that because you preserve the function of the vessels that they are supplying the tumor superior. So from this, if you see, this happens in outside hospitals. In the residual tumor superiorly. I brought just this case for all of us to be careful. Although it was the outside hospital case, but I wanted to bring it up. The last thing that I want to discuss, we wrote a book chapter with Pablo and Ron and the whole team in the Schmidt suite. We discussed the rare indication of transcranial surgery for pituitary adenoma. The thing that I really obviously we don't see that they cannot tolerate being off CPAP, but if it's like that, then it's an indication for transcranial surgery. But we see a lot of people that they are on CPAP. What to do with these people? I think the best way is this paper described very nicely. They say if it's a CSF leak, very low grade, you need to be off CPAP for 2 weeks. If it's high grade means you see the real CSF leak is not just because salmonella or it's like a high flow CSF leak. You need to be off 6 to 9 weeks of CPAP and make sure with endoscope that you confirm the repair. Otherwise, is a risk of getting the esophagus and air through the defect if the patient uses CPAP. I think I do the conclusion here. Management of pituitary tumors needs team approach, neurosurgery, ENT, endocrinology, ophthalmology, even monitoring, all of this. Mastering the anatomy and using the new technology empowered all pituitary surgeons to use the surgical skills to push the boundaries and safely optimize the surgical results. We have to be very careful and see the long-term results of anatomically based technique like this medial wall dissection, and it should really be done very, very technology and empowered all pituitary surgeons to use the surgical and done with skills to push the boundaries and safely optimize we have to be very careful.
Wonderful, Hamid. Thank you very much for a really nice overview on many aspects of treating pituitary tumors. I remember I was told some years back that by a colleague who, didn't do pituitary surgery, that the pituitary surgery was easy. And I think that came out of ignorance a little bit, knowing that he had not performed pituitary surgery in probably 15 to 20 years. So things have really changed, as you have nicely shown. Certainly for the participants.
One thing I mentioned as I was doing this presentation, I remember always like the discussion that we had together, how important it is. I try to highlight the thing that we always discussed together. I realized in my first year of practice how important it is.
Well, there's no question that we are all learning all the time, and trying to modify our practices so we get better. First of all, let me just comment. If you are on the line, we have 42 participants in addition to the panelists. on the line that you can send any questions to Dr. Borghi-Razavi via the chat. I'm going to get our panelists involved here shortly, but Hamid, I did want to be a little bit more specific. I had a few questions, but um, um, but to start out, you showed some new technology and the use of the ICG green. Can you
Exactly.
comment? I mean, you showed an initial experience, but obviously that has not been widespread yet. Where do you foresee that going in the future?
I think because you see the real anatomy, I think it will be very useful because it makes you. I mean, we have always Doppler, but as you see, this acromegaly case that I did, the bone was so thick, even I was not able to treat it with Doppler. I had to open the cella and make the cella a little bit deep, and then I use the Doppler to see how the Doppler. I think in some challenging cases that we are not sure about the therapeutic area, and because we see it in the real anatomy instead of having it like a fluorescent, just a black bead. I think it's really a room for that.
So do you think that means like in more of those poorly pneumatized cases, you know, concal anatomy or
Exactly.
you know,
Exactly.
okay. Fadi, JP, Varun, any comments from some of the other panelists? So do you think that means like more of the poorly
Hamid, first of all, congratulations on your presentation. I think I'm having an issue here with my camera. I'm sorry. So, first of all, congratulations, beautiful talk, and beautiful cases as well. Uh, the one point that I wanted to bring up for discussion for everybody is regarding really as you were describing, the anatomically based techniques. Well, we all know that all surgical techniques are anatomically based, but I think we're talking about the medial wall resection of the cavernous sinus. It is somewhat controversial in what cases we're going to use that and how we're going to pursue them. What is your impression of this technique and the future of this technique? Do you think we're going to, start doing it more and more, or are we going to actually become more and more selective about this technique?
I think I will be, at least for me as a like newly started in future surgery, I will be very careful to do that at the beginning. But as I showed in this Japanese paper, at least I want to go and then watch the wall with the 30-degree or whatever endoscope you are having to set up like 45-degree or 30, to make sure the wall is not invaded. If the wall invaded, at least I would coagulate the wall because really pre-op MRI these papers it doesn't show really if the wall is invaded or not. It can help us to have some idea, but if I see the wall invasion, I would coagulate the wall, and if I get more comfortable, I will resect the wall in the future if it's really invaded. But the thing is, sometimes you have like the tumor going all the way to the cavernous sinus. That are the easiest one because you can just get the tumor out of the cavernous sinus. But if you see that it's touching the wall, then these are the challenging cases. Actually, we have to think if you want to coagulate the wall or resect the wall. I think Varun and Pablo they have also a lot of experience. They can help us also. I mean, we can hear their idea.
Yeah, Varun, do you want to comment there?
Yeah. Well, first of all, great talk, Hamid. Just to comment, I feel like we love to talk about the medial wall because it's the most sexy, part of technically challenging. But we just have to remember it's dura, just like the floor of the sella, the dorsum dura. And so in my view, it doesn't make sense to take all the risk and do the medial wall, and then you leave the whole floor of the sella dura. So I think, if you want to take a lower risk approach, it may be reasonable in the beginning, at least start with cutting out the floor of the dura or separating the two leaflets on the floor and peel out the meningeal layer, or generously coagulate all the dorsum sella, you know, and then move towards the cavernous sinus. I think the jury's still out a little bit. You know, I know Juan Fernandez Miranda has been kind of pioneering that work and data, and he has some more updated data showing that the highest risk cases in his experience are the growth hormone secreting tumors that have the highest percentage of invasion. You know, I will say, you know, even though you showed that one paper showing that size doesn't matter and hard to predict, you know, I will say the cases in small tumors, I have not seen a single one of those medial walls come back positive. They're all negative in the ones I've done. It's only been the bigger tumors that have come back positive. So, I mean, it'll be interesting to see. I don't know.
And I think coagulation, I have done like 5, 6 functional that was invaded, and I coagulated the wall. All of them went to remission. So I didn't want to bring it officially in the presentation, but really we need a prospective study to see like is enough, like Simpson grading is enough to coagulate, or is we have to really resect.
It's definitely a challenging comparison, because of course you can have the cells that are coagulated, as Hamid has brought up, and of course we do see patients that with Cushing's disease or with one of the other functional entities where they were touching the wall and then they recur and the wall is intact, and at the end of the day we don't know if that's where the residual tumor cells are or not. And when we treat them, if we treat them with radiosurgery, for example, we target the whole cella, but realistically, or we can target the whole cella. I know we tend to do that here. But alternatively, if you're not targeting the whole cella, you still will target that floor and that medial wall that is still present there. But it's tough to really measure that and compare.
I think all of us agree that it's good to inspect the medial wall carefully when we do the tumors close to the medial.
Hamid, you presented 2 very large tumors at the end. One of them, which we did together. You mentioned an 80% estimate as an estimate that had been out there in the literature, where if you can't get at least 80% out, that you should maybe start transcranially. Can you be a little bit more specific of what goes through your head in making a decision? Is it the height? Is it how far it comes over the anterior skull base? I know that last case, for example, really curved over the anterior skull base, tuberculum planum. Is it how lateral it goes? What kind of things go through your head in making that decision?
I think this 80%. I was looking a lot in the literature. Actually, it's really nothing in the literature about that. There are some few papers from different institutions, as like a case report, but I found this 80% in one of these papers, that one of the experts' opinion. Obviously, there's no clear data on. But in my practice, if I feel that the tumor is going not completely in the midline, going to the temporal lobes and toward the sylvian fissure laterally, I don't feel comfortable to do everything with endoscope. Then this is the time that I will think about doing transcranially first to prevent these things to happen.
Yeah, I personally remember a case early on in my experience where the patient had a growth hormone secreting tumor, a very vertically tall tumor, and then also a component of the cavernous sinus. That patient, we cleared out all the central component. Interestingly, she hemorrhaged just like you presented, except because it was in the cavernous sinus, it was largely contained, so she didn't have a catastrophic intracranial hemorrhage. But it is it's certainly a treacherous thing. Varun or Badi or JP, do you want to comment on any of that further? Varun, I know you've had many cases like that.
Yeah. You know, I'm sorry, go ahead, Varun.
Okay. Yeah, I was going to say, I completely agree. I use the same philosophy. It's interesting to find someone published in 80%. I've always, just conceptually in my head, randomly picked the number 85. But I don't, it's more so, and I think that is different from surgeon to surgeon, right? You know, you have to see in your own hands and experience what you feel like you can get. And so I typically, and again, it's the middle fossa or lateral extension, lateral to the optic nerves. You know, those are the ones, if I can't get the vast majority, I'll go transcranial first. I have had, just for the counter argument, one time on a giant adenoma with lateral extension, we removed everything except the sella. So we actually removed more than I anticipated from above. And the residual in the sella and left cavernous sinus, basically on post-op day 3, he manifested as a cavernous sinus syndrome. We repeated imaging, and he had like an ischemic apoplexy of the residual tumor. And so we took him, and you know, it was all semi-ischemic necrotic tumor, and he recovered. But that was one time where, even though we came from above at top, he had an event from below.
Yeah, I think those presentations are interesting, right? I think what Hamid mentioned about the limited data available in the literature about this topic is to be considered. And when we look at different series of giant adenomas being resected by an endoscopic and a nasal approach, we do have large series with gross total resection rates that basically fluctuate between 35 to 50%, and then somewhat higher in specific groups. But the gross total resection of giant adenomas, especially like invasive adenomas, we know that that rate is really not that fantastic. It doesn't matter what approach you make, sometimes they're just complex tumors. And we don't see tons of those complications being reported in the literature. So I think either we need to report more about this complication that we all talk about, but we don't see that quite often reported, or we are doing a problem like of underreporting such complication. On my own personal case, the other point that I think is interesting to always look is, as you had in your case, Hamid, that how thin or how thick is that waist of the tumor that extends from the cellar compartment all the way up to the suprasellar compartment and sometimes lateral to the optic canal. I think that the thinner that is, the more likely your tumor is to go through apoplexy after a partial resection as well.
Just to mention, it was not my case. I wanted.
No. I mean, I'm sorry. I mean, the case you presented.
Yeah, but it happened for all of us, and actually, I'm learning from this to be more careful with selecting the cases. And this was the reason I brought it in discussion. You are right. If it's going toward the middle fossa, I would do probably transcranial first.
There is one question on the chat. It says, could you please, from Hamid, could you please speak to which tumor characteristics you look for extracapsular versus intracapsular tumor removal?
I think the thing that I learned, normally non-functional tumor, we don't really do extracapsular dissection for non-functional adenoma. So because non-functional most of the time is very easy to correct them out, and then with 30-degree you can look around and you can remove. But the functional, obviously, as I showed in the data, I would go 100% first for extracapsular dissection to preserve the gland and also get the capsule of the tumor, which are like invaded cells completely. But as I showed, some non-functional also, you go there and then you see how difficult it is to correct them and to take them out. Then I start in that ones. I also start to do extracapsular dissection. And if it's not possible to do extracapsular dissection, I use sonopad, and I try to do extracapsular dissection and slowly bring it from the cavernous sinus in, and then use the sonopad.
Okay. Is there any other comment from?
The last thing that it has been in my mind. I want to bring it up because it's a question of a lot of us probably. I want to bring it up for the panel. So I saw a few days ago a report, in the news, that in one hospital somewhere they did a very successful surgery of a small Radke cleft cyst in the patient with severe headache, and the headache completely gone. So I realized that all of us see in the practice the pituitary tumor, the small pituitary tumors come with the headache, or like Radke cleft cyst come with the headache. So I never thought it's an indication for surgery, but as I saw this, I thought, oh, the people are thinking about doing surgery on Radke cleft cyst to relieve the headache. And then I discussed a little bit with the person who did the surgery, and he said they do follow up, they do complete workup, and if it's the headache is not improving, they operate on the Radke cleft, or any kind of adenoma, like they are tiny but they make headache. So for headache indication, I wanted just to get the panelists' opinion. Do you operate the pituitary tumors for headache?
I think you were thinking that this session was going to last 2 hours, Hamid, instead of 1 hour, because obviously you've just thrown out a bit of controversy. I personally, in my practice, do not use headaches alone as an indication with an otherwise complicated adenoma. Of course, if you're talking about the adenoma extending into the cavernous sinus and things like that, but that alone does not tend to be an indication for headache, at least for surgery in my practice. I do think that there's a couple things to remember. There was a paper about 5 years ago put out by Ed Logg's group, and they looked at, longitudinally headaches in patients with pituitary lesions. And certainly in the context of a strict study and a headache group, they were able to pinpoint a percentage of the population that improved. I think part of the problem, though, and this has been shown in the past, is there can be a large placebo effect. So is that going to be a lasting thing? The other thing is that the sort of the more invasive the nature of a procedure, the larger the placebo effect can be. So I take that with a lot of caution. Certainly, is even for experienced pituitary surgeons, there can be cases that are reasonably uncomplicated, but they're never without any risk. And to operate on somebody with something quite small for the indication of headaches, and if there would be an unfortunate complication, I think would be a disaster, and you start walking the line of whether that's malpractice or not. But that's my controversial statement. Varun,
yeah, I would agree with all that. There was also a nice paper out of the UK where they prospectively did a validated headache survey and longitudinally followed people who had headaches and then had surgery for pituitary adenomas, not for the headaches, but for other reasons. And only about 50% of people improved. So it's kind of 50-50. Theoretically, maybe Rathke's might be a little bit higher percentage. But it's funny in patients who, everyone gets MRIs for headaches these days, right? And it's not uncommon. We find, an incidental lesion. It could be an adenoma. It could be a meningioma. And it's not uncommon when we just observe it and I see him back at 6 months or a year. And I'm like, oh, how are your headaches? And they're like, wait, what do you mean? I was like, remember, like you got the MRI for headaches. And like, oh yeah, those went away. So like, don't underestimate just a tincture of time and observation that a lot of those patients, will get better on their own. The one, again, not that I use it as the sole reason for surgery, but patients, who do I think are more likely to be connected? Some variation of the sunk headache, where it's unilateral, retroorbital, very sharp pain, can be associated with tearing or rhinorrhea in a patient who otherwise does not have a long-standing history of headaches and migraines. That, in my mind, gives me a little bit more suspicion, and especially if you combine that with evidence of hemorrhage, potentially in an adenoma, those are signs that I might be more likely to link it, but still not necessarily, for me, that would not be a sole reason to do an operation.
No, I agree. I wouldn't do a case just for the sole reason of headaches.
Okay. Well, this has been a great presentation, Hamid. Great discussion with the other panelists and team members. I want to thank everybody. Thank you, Hamid, for your preparation, your presentation, and thank everybody who attended, this session. And we're excited and look forward to having everybody on the next one.
Thank you so much.
Have a good night. Good night to all, or a good day wherever you are.
Good night, everyone.
See you next week.
See you.